Welcome everybody to this Healthcare Without Harm Europe webinar on the water footprint of the healthcare sector, organized in the framework of the WaterEDUCare project. In this webinar, we will analyze the hospital water footprint and provide actionable strategies to protect our water resources without compromising, of course, patient care. But while we allow other people to access the room, let me remind you of the format of this session. We'll have 4 speakers who will present for around 10 minutes each. After all their presentations, we will have a question and answer session where all of you will be able to ask any questions you may have. I can see that the room is getting filled. You can use the chat to introduce yourself as well, so that we can see where do you come from, and you can also see who are the other people attending this webinar. And as you may know, daily tons of medical compounds ranging from contrast agents to antibiotics enter European waterways, driving human health impacts such as accelerating antimicrobial resistance, for instance, and disrupting fragile aquatic ecosystems. The healthcare sector has therefore a huge water footprint that can be addressed and reduced with concrete interventions, some of which will be presented today in this webinar. Healthcare professionals occupy a strategic position to mitigate this impact. So we are very glad of the interest that this webinar has raised among healthcare professionals, and we hope that you will get out of this webinar with some ideas and some inspiration too. And with no further ado, I will introduce our first speaker, whose name is Alistair Boxall. He is a professor in environmental science, and his research focuses on understanding emerging and future ecological and health risks posed by chemical contaminants in the natural environment. Welcome to this webinar, Alistair. The floor is yours.
Okay, I'll just share my screen and then get started.
Take your time, no problem.
Okay. So hopefully you can see that.
We can see your screen. Yeah, now it's in full screen mode.
Brilliant, good. So good morning, everyone. It's really nice to be with you today. What I'm going to do in the next 8 to 10 minutes is talk a little bit about some of the work that we've been doing, looking at understanding and managing the risks of pharmaceutical pollution globally. I think I'm probably preaching to the converted here, but pharmaceuticals can be released to the environment at all stages in their life cycle. So we now recognize that in certain areas of the world, manufacturing can release quite high concentrations of pharmaceuticals into the environment. We recognize probably the most important route for human medicines is treatment of the patient and excretion of the pharmaceutical by the patient to the wastewater treatment network. And then we have the whole area of veterinary medicines. So in aquaculture, medicines can be applied directly to the environment. When we think about livestock treatments, the manure and slurry from treated animals can be applied to fields, and that can carry the chemicals onto the soil. And then we're starting to recognize, certainly in the UK, that the pets are also part of the problem. So we're now using a lot of things like flea treatments and wormers in our pets, and we're starting to detect those in the environment. And then obviously once the pharmaceutical is out of date, that then can be disposed of. If it's disposed of inappropriately, it can be going down the toilet into the sewage treatment system. But even if it's disposed of in the trash, that then can enter a landfill and be released into the leachate. And this is a problem that's been recognized now for about 20 or 30 years. So in the late 1990s, the first sort of big monitoring studies around pharmaceuticals in the environment started to appear. But in 2017 and 2018, we led a very big global study to try and understand the scale of the problem. And in that study, what we did is we monitored 104 countries. We monitored 61 different pharmaceuticals in rivers. And what we found was that pharmaceutical globally is very widespread. So we were detecting pharmaceuticals in 909 of the 1,052 sampling locations that we monitored. The graph there shows an indication of the types of concentrations that we saw. So if you have a sort of a blue country, the levels are lower. And if you have a red country, then the levels are higher. And you can see that we're seeing the highest levels of pharmaceutical pollution in sub-Saharan Africa, in countries in Asia, and also Latin America. And on the right there, you have a photo. That photo is of the most polluted site that we monitored. So that was a river in La Paz in Bolivia. And the buildings in the background, if you go to Google Maps, that indicates that area is an area of generic manufacturing of pharmaceuticals. So we think the high concentrations that we were seeing at that site were down to pharmaceutical manufacturing. So we're seeing widespread occurrence of pharmaceuticals. The question is, is this causing harm? And there's a lot of data now suggesting that the concentrations that we see of pharmaceuticals in the environment might be of concern for organisms in the environment. So here are a few examples. So studies with ibuprofen over long-term exposure show that at quite low concentrations, ibuprofen can affect the hatching of fish. Diclofenac studies have shown that at low concentrations, you get effects on liver histology in fish. We're seeing that antidepressants can affect the behavior of organisms, so they affect how fish behave, how invertebrates behave, but also how birds behave. Synthetic estrogens can alter the reproduction and sexual characteristics of fish. And then antibiotics seem to be particularly toxic to primary producers, so they're affecting things like algae and cyanobacteria. When we take the data from the literature on effects of pharmaceuticals and we compare it to our monitoring data, what we find is that 4 in 10 river locations have concentrations of at least one pharmaceutical of concern for ecological health. But it's important to recognize that these chemicals don't occur on their own in the environment. So one of the locations that we monitored, we detected 34 different substances. And this then raises the issue of multiple chemicals affecting different species in the environment. So we've got a situation where at some locations, you've got chemicals affecting the growth, the photosynthesis, and nutrient cycling in primary producers. You've got chemicals affecting reproduction, response to light, heartbeat, and morphology in invertebrates. And then you've got chemicals affecting reproduction, the behavior, sexual characteristics, and histology of fish species. So we have a situation where you've got mixtures of pharmaceuticals having mixed effects on mixtures of species. And we're also concerned about potential risks to human health. When we look at the concentrations that we monitor and we compare it with acceptable daily intakes, our general conclusion is that the risks are quite low, but our main concern is an indirect risk. So it's due to the potential for antimicrobials in the environment selecting for resistance in microbes and possibly contributing to the antimicrobial resistance crisis, which in 2019 killed 1.2 million people globally. When we take information on levels that have been proposed by industry that are safe for resistance selection, and we compare those levels with the monitoring data that we've obtained, what we find is that 1 in 5 locations around the world have concentrations of at least one antibiotic that we think are high enough to select for resistance in bacteria. So this certainly indicates that the environment is probably an important contributor to the AMR crisis. So what we're seeing then is that pharmaceutical pollution is widespread. The levels that we see are high enough to affect ecological health. They're high enough to affect human health through selection of antimicrobial resistance. So the question is then, what can we do about it? Last month, I was lucky enough to receive funding from the Rockefeller Foundation to do a Bellagio residency. And I went over to Italy to Lake Como, where I spent a month just really trying to think about how we begin to solve the global problem of pharmaceutical pollution. During the month, what I did was I began to look at different solutions for fixing the problem of pharmaceutical pollution. I came up with 10 different potential general solutions, which are shown on this slide. And then I worked to begin to rank them in terms of how important they would be in terms of impact on the levels of pharmaceuticals and the impacts of pharmaceuticals globally. At the top of the table, we have the most important solutions from that exercise. So you can see that wastewater treatment, so this would be introduction of tertiary treatment methods, but also new decentralized methods will reduce levels of pharmaceuticals in the environment, improve regulation, so introduction of global environmental quality standards for some of the more hazardous molecules, and then better monitoring and ecopharmacovigilance, so we begin to understand the levels more broadly and ensure that the mitigations are actually working. And then as you move down, you can see at the bottom, even though people have talked quite a lot about it, safe and sustainable design, I rated as low to medium importance because of the time scale that would be involved in sort of introducing that as a solution. I also identified a number of actions that I think we need to do as a society to implement these solutions. So this includes focusing on a number of research topics, which are shown here, better data sharing and collection of data, better governance and regulation, changes in funding mechanisms to support the introduction of some of these solutions, and then focusing on education and behavioural change. So webinars such as this, I think, will help in that regards. So just to finish then, I think I've got about 20 seconds left. Hopefully what I've shown you is that pharmaceuticals are released to the environment during their manufacturing, use and disposal. Their occurrence is widespread. The problem is most acute in low and middle income countries, and it's typically at sites in cities that receive manufacturing inputs or which have poor waste and wastewater management infrastructure. We detect things like painkillers, anti-inflammatories, and antimicrobials at the highest concentrations. And when we take the concentrations that we see for some of these substances and we compare them with safe concentrations for ecology and for resistance selection, we see that a significant proportion of sites monitored globally have levels of concern for ecological health and also for human health. Through the Bellagio residency, I've identified a number of potential solutions that could be applied to address the problem. I'm sort of just finalising the document from that residency, and that should be available soon. And what I'll be working on over the next few months is sharing that, and hopefully people will start to adopt some of the ideas and implement them. So thank you so much for your time, and I will stop there. Thank you.
Well, thank you very much, Alistair, for the presentation. I think it's really relevant, and I'm pretty sure that we will receive a few questions for you in the chat. It's always worth to note that we are already beyond our safe operating space, let's say, in our planet when it comes to novel entities and pharmaceuticals. So even if we know that, I always feel a bit afraid when I see all this data about pharmaceutical pollution and how it's impacting disproportionately also the manufacturing countries. And we are the end users. Of course, here there is also a huge impact, but obviously communities, people that live around these manufacturing facilities are most impacted by this. Thank you very much, Alistair. And I will give the floor to our next speaker, who is going to speak actually about one of the compounds that is mostly used in the healthcare sector, contrast agents. His name is Ben Jansen. He supervises the pharmacology and pharmacotherapy teaching programs in the Faculty of Health, Life Sciences and Medicine of Maastricht University. He started a new research in 2019 on the potential ecotoxic effects of medical waste products present in wastewaters of hospitals and surface waters. And as I said, he's going to present the results of a research on how healthcare settings can reduce the emission of contrast agents to the aquatic environments. Welcome, Ben. The floor is yours.
Thank you very much for the introduction, nice introduction. I'm a pharmacologist. Can you see all my screen? I'm just, has it been shared?
Yes, we do.
Okay. I'm going to tell you what we did to actually try to reduce, say, the emissions of the hospital regarding contrast agents. And we did a study here in Maastricht, and here you can see the River de Maas. And what I'm going to tell is published in European Radiology, and I'm going to show you how easy or maybe how difficult it is to do really a clinical intervention and to monitor and to see the outcomes. You can see the Netherlands. We have quite some rivers. Here we have the Maas, the Rhine, and some other rivers. And in the Netherlands, about 40% of the inhabitants make their drinking water from surface water, and from the Maas, it's about 7 million people are dependent on the quality of that water. Many agents are in this water, and especially contrast agents. I will show you later on. Here we have our hospital, which is an academic hospital, a large hospital. We have these contrast agents getting into the water because we make a lot of CT scans and we make MRI scans, and we use contrast agents for that. The Maastricht Hospital has 4 CT scanners, 4 MRI scanners, and we have a more regional hospital that's in Weeswurland, a little bit further upstream, and we only have 1 CT scanner and 1 MRI scanner, so it's a smaller hospital. Here you can see one of these iodinated contrast agents for CT scans that are used, and you see 2014 to 2023, and this is the River the Rhine. We see a rising pattern, and there is a threshold level for the European River Memorandum, and we see we are exceeding that more and more. When these patients, say, get these contrast agents injected, you make a scan, then they're going to release and emit these contrast agents. They're very water soluble in their urine. And usually in patients with a normal kidney function, most of the contrast agent has been released into the urine within 24 hours. And of course, then it gets into the sewage pipes and then finally in the wastewater treatment plants. And here you can see now, well, look to one of the gadolinium-based contrast agents that has been measured very recently. And here you can see in tap water, and you can see Amsterdam, Berlin, Dortmund, a lot of these contrast agents are appearing at high concentration. Well, high, it's nanograms per kilogram, nanograms per liter, but they are present in tap water, and we drink that all the time. So these agents are very resistant for getting them out the normal treatment pathways. And well, there are many ways to place an intervention, and our Dutch government has promoted the use of urine bags. I say, well, hand out urine bags, then the patients they get 4 urine bags, then they pee in these bags are then thrown in the normal garbage bin. That's incinerated, so that does not get into the wastewater treatment plant. And so we were wondering, because they spend a lot of money on this, well, do we really see a reduction in wastewater treatment plants? So I set up a study to do that. We had a double center, was a prospective study in Maastricht and Roermond. All the patients that were scheduled, and mostly the ambulant patients for the CT and MRI scan were included. And when we decided not to hire extra personnel, because if it works, it should work in a normal clinical setting. So we provided some promotion materials in the waiting rooms, and we had some students to call up the patients, but I really used these urine bags. We did it for a period of 3 weeks, and then we had a control period without handing out these urine bags, and then of course our intervention period was with urine bags. Let's show you some, and then what were our outcomes were, of course, the primary ones. How much gets really into the wastewater treatment plant? What do we see? And because hospitals use different agents, we also had to try to measure the different agents to get really a good pattern. And we had some secondary outcomes. We looked at the success rate of the distribution, the patient compliance, and the number of bags, etc. Well, this is just show you how many patients were included. We had 1,805 patients included. And in about 2/3 of all these patients, we could handle the urine bag. So 1/3 wasn't possible. They were too sick, all kinds of hearing problems, language problems, not interested, etc. In this group, we could hand a urine bag, but they did not complete their informed consent, so we could not phone them. So that is about this group. Then this group, they got a urine bag, provided informed consent, but we tried to phone them, but that was not possible, that we could not reach them afterwards. And so we only had this yellow group 558, which did respond to our phone calls and used urine bags, and we could verify in this group that 80% of all the bags were used. So that is quite good. And so potentially 2/3 might use the urine bag, but we could only verify it in, say, about 1/3 of the whole group. Now let's look what we found in the wastewater treatment plant. Here you see days from 0 to 20, so 3 weeks. And this is the cumulative amount that we found. And this is the CT iopramide agent. And then you can see here Wednesday, Thursday, Friday, Saturday, Sunday, because then the CT scanners are not so active. So, and then we get a whole week again. And then in the end, in 3 weeks, 50,000 grams, so 50 kilos was handed out. The blue period was our control period, and the yellow period was our with handing out. So the input was the same over these 3 weeks. And then you can see what we recovered in the wastewater treatment plant very close to the hospital. And we found about 35 kilos, and we found a reduction of 21% here. There are many things to discuss, but I'll first show you the data. And this is about the small hospital. You see the same weekend pattern, the same amounts given out in these 3 periods. And you see a small reduction here as well. But this reduction is certainly not 2/3. I'd say when you would assume that all the patients would use all the urine bags we were handing out. Then this is for the gadolinium-based contrast agent. Here we see a steady rise because in the weekends, these MRIs are also running in the weekends continuously. So there's a lot of demand on that. So we have, again, the same amount. And then the mass rate, we found only from the 700 grams, and this is the metal only. So it's not the whole agent. So we only measured the metal. We found about 200 of the 700 we could retrieve in a wastewater treatment plant. And Roermond, there was handed out about 100 grams was injected IV, but we found 200 to 300. We found even more in the wastewater treatment plant. And we could see reductions, but they were relatively small. So there are lots of things to discuss to explain these things. The most obvious one is this one. We had the postal codes of the patients because there were ambulant patients where they were living at home. And now when you look to the Maastricht Hospital, which is here the yellow one, and here is the green wastewater treatment plant, and this is the area where the wastewater treatment plant gets all the processes of the sewage water. All patients come from a very large area in the academic hospital. When you look to the regional hospital, more than 95% of the patients live in this area, and only a few come from another area. So that's really a local function. But academic hospitals can have even a national function. We also have patients coming from other places. And the same was true for the gadolinium-based contrast agents. And you see white dispersion here. and there. And this could already explain, see, our patients also live in this region where that hospital is, and we found even more gadolinium-based contrast agents in this area than was even handed out. And we have another hospital here, another hospital there. So all these other hospitals are maybe hospitals from Germany, because patients can also go to Germany or Belgium, might do that. So it's very complex to control all these factors and to make the readings what you have to get really strong conclusions how such an intervention, which looks simple, how good it works. So that's one of the first conclusions I would draw. So summarizing your things, I think our urine bags are helpful. Yeah. The overall effect size in handing out is between 1/3 and 2/3. We're not sure because it's very difficult to reach everyone. We are happy that we could reach about already 1/3. The effect is small at the wastewater treatment plants. That's relatively small, but there is, of course, a huge dispersion of patients. And then to get that, you should monitor all the wastewater treatment plants at the same time, and then you should do all the hospitals at the same time to really try to measure. But that's a logistic nightmare, I can tell you. Even for 1 or 2 hospitals, it's already complex. And then also handing out these urine bags, they are produced in China, they're transported here, it's plastic, it's incinerated. Is it really helpful? So we cannot answer this question, and also the costs that are involved, not only the carbon dioxide that's produced, needs information. And I showed you the increasing levels in the rivers of these agents, and they are in the drinking water, but we really don't know if there is long-term potential toxicity, whether they are piling up. There's some evidence that gadolinium is maybe remaining in the brain, and then what happens over years, we really don't know. I don't know. So what can you do more? The best thing is to make, as also Alistair pointed out, do not use the agents. We can make more scans without contrast. There's AI, we can increase resolution of the pictures they get, better imaging, AI. There are new agents developed who will have less impact, and we can prevent all the wasting in the hospital. We can install special toilets, so if a patient gets a scan, we will ask the patient, and we are trying to investigate this, to remain here for 2-3 hours, and then that's also about the half-life, and then they pee here in the hospital. So that should be included in the normal procedure. When you get a scan, you must stay for 2 hours in the hospital. We have a special toilet, and then we can collect all these contrast agents. Well, installing a general filter, that's a complex thing at hospitals, and installing all kinds of measures at wastewater treatment, that's also a complex things to get rid of these agents. And so with this message and these considerations, I hope I gave you a little insight in what we have tried to do, and I'm happy to answer some questions. Thank you very much for listening.
Thank you very much, Ben, for the presentation. You indeed presented a very good example of reducing pollution in the point of source. And I'm gonna pick up on one of your messages that is actually the one that we usually also share when we go to conference, when you mention that what we need to reduce is the unnecessary use, like when you mentioned, like make more scans without contrast, or even, avoid doing some of these tests if they are not necessary. We always use this phrase, like the main reason of pharmaceutical pollution is pharmaceutical use, which of course is needed, but in many cases, there are other actions that we could take, or there is a further research that has to be done, like in the case of antibiotics, which is our next example. I will only ask you, Ben, if you can stop sharing your screen.
Yes.
So that I can give the floor to the next speaker, who is gonna drive us through the results of a recent project on antimicrobial resistance. Her name is Camille Lassalle. She's the Safer Pharma Project Officer at Healthcare Without Harm Europe, and she has coordinated the AMR WaterEDUCare project, which has trained over 6,000 healthcare professionals across Europe. Camille is going to present to us how vital training is for clinical and non-clinical staff to reduce pharmaceutical pollution, and more specifically, antimicrobial resistance. Camille, the floor is yours.
Thanks, Eric, and good afternoon, everyone. So as I'm following up on Alistair and Ben, they both highlighted different solutions when it comes to pollutions. And one can be to change an entire yard habits, introducing new way of proceeding, but also as Alistair has highlighted, education and behavior change are also a key part of the solution. So I'm now sharing my screen to share with you this example of the WaterEDUCare. Oops. Here it is. You should be able to see that. No, it doesn't want to. Yes, it should be fine. I see you noted. Can you see my
Yes,
screen?
it's working fine.
Yes. Okay,
Yeah.
perfect. So now time to share with you this project and experience on accompanying healthcare professional towards a change in their practice to reduce IMR, to mitigate IMR. So how that's started, it's a consortium of 12 partners within Europe who set together to create an e-learning targeting specifically doctors, healthcare managers, nurses, and pharmacists to change their practice, to change their behavior and communication towards the mitigation of AMR. All started from this observation from an ECDC surveys where they assessed knowledge, skills, attitudes of healthcare professionals towards IMR knowledge in general, but also competencies and behavior. What they observed in this survey is that there were a lack of training overall on IMR, even though IMR stewardship is more and more common in curriculum. The global way of looking at IMR was missing there, and evidence were showing limited focus on behavior change. And it's also what Alistair highlighted earlier when it comes to pharmaceutical pollution, that focusing on behavior change is also a solution. So the goal of this training was to target improvement in communication with patients, to the way they address patients' questions or the way they deliver information when it comes to treatment, but also disposal as one of the aspects of it. It was also targeting the prescribing. Ben was mentioning earlier that the first one is to reduce. So is to reduce the amount of medicine we have to reduce the problem. A third goal of the training was to increase understanding and application to responsible antibiotic prescription. So reduce prescription, but also the way we prescribe, and overall then increase the knowledge. So on top of having this common stewardship knowledge e-learning, it was to integrate the One Health perspective and integrate different perspective. So one was to have this antimicrobial waste reduction and disposal components, and it's linked to environmental knowledge within the course, on top of having communication skills, specific content. Throughout the course, behavioral knowledge were integrated. When I say behavioral knowledge is first targeting healthcare professional, meaning that throughout the course, when they would follow the course, they would be asked where they stand in terms of the perception of the problem, the self-efficacy, so how confident they are to share the information with the patient. So it was not only about behavior change towards patient, but towards themselves. Do they feel confident that they can take actions in their yard, or are they the only one that are as aware of the problem? So these are examples of how the course looks like. So it's not just dispensing knowledge, but it's also having case studies that meets their real life situation they might encounter. On top, as you see on the left, is not only focusing on the problem within the yard, but it's to understand the global picture. So it's from waste disposal, but also its links to the environment. And all of this was part of the training. On top is digital integration of knowledge. So, of course, is to show that some solutions are there to help and support behavior change within the practice, to help the different actions, or to help, for instance, a yard to take a different direction. These are the results of this training, as Eric was mentioning. More than 6,200 healthcare professionals were trained within Europe. So we had medical doctors, nurses, pharmacists, healthcare managers. At first, the training was focusing on 6 countries. It's now open and available in English for everyone who wants to take it. And interesting findings we had were regarding the profile of healthcare professional were taking it. Healthcare managers were specifically interested. And when we investigated the reason why, is that they were not offered so many options of training. When we usually think about IMR, we think of the stewardship that is usually targeting doctors, while healthcare managers or nurses are not specifically targeted in the content that is delivered, which explain why, when this course was launched, a specific interest arose. When we dive deeper into the effects of this training on their knowledge, attitude, and actions, we saw that a short term, so right after they took the training, they reported increase of knowledge by having this training. Yes. Then the biggest change in knowledge were assessed through towards nurses and pharmacists. This follows the same logic as what I was describing earlier, that they usually don't have so much content regarding disposal or even environmental health in their curriculum. So this kind of training is new, and then the room for improvement is shorter. When we focus on the midterm, which means a few months after they follow the training, they reported a change in their antibiotic prescribing. This specifically targets prescriber, but also a change in their disposal procedure, even at an individual level. When it comes to longer effects and long-term effects that were more the way we assessed the intention to change, the way they would implement change or ask the yard to change. And these were high results of, as we see here, around between 80-90% of this desire to change, or the intention to change, or at least having a plan to provide knowledge in a different way, or to dispose medicines in a different way. As we were focusing on their behavior change, but also how they would use behavior change science to discuss and communicate with their patient, we also assessed the change they observed 3 months to 6 months after the training, and they felt overall more confident to raise those concerns with patient, or also to respond with patient who would maybe be insistent on getting antibiotics. They felt that by having this knowledge, they would change the word they were using, or felt more empathetic towards the demands of their patient, and way to explain and train them on that. Overall, also healthcare professionals were really satisfied with the training and recommended it to their colleagues. So when we looked at it, we came with some conclusion on how this training on IMR could be also exported to other projects, as and other topic has pharmaceutical pollution. Like, first is having more collaboration, because AMR trainings, they exist throughout Europe. And the idea is to not reinvent trainings, but to complete them where there is a gap, for instance, targeting healthcare managers or having specific trainings for nurses practice. So it's to be able to have a view on what exists already and to complete it. Also be aware of the growing gap. For us, we are aware that it's important to also train healthcare professionals to environmental issues, but few years ago was not part of the curriculum. So there is a gap in knowledge when it comes to pure science or the effect of medicines and the effect on the environment. So when creating content, it's important to keep that in mind, to go back from scratch and come with a basic explanation of those processes. It's important to integrate behavior change principle, both for the learning practices, but also has key messages and knowledge they can export. And then it's to have this continual medical framework within Europe. As we know, when it comes to university, we're all aware that there is this ECTS version of recognition of skills, but it doesn't exist at a professional level yet for healthcare professionals. And this by having a common understanding and a common definition of knowledge in continual medical education, it could ease this knowledge sharing within countries, within healthcare professional. And this is what we took those learnings in the WaterEDUCare e-learning that is currently under development and will be launched soon to integrate those knowledge and accompany a healthcare professional to change their practice, to first be more aware of pollution within pharmaceutical pollution within water, but also to take actions at an individual level, yard level. And these are examples of, as Alistair was presenting earlier, start from scratch. Understanding of the state of the art regarding Europe, regarding water in Europe, to actions they can take. So this is all I wanted to share with you for today. Don't hesitate to contact me if you have any questions, and you will have more information regarding this WaterEDUCare e-learning. Thanks a lot.
Thank you very much, Camille, for the presentation. And as I understand, you are joining us from Lyon, where the One Health Summit is happening, and where you are also presenting the WaterEDUCare project results. So I guess this project is getting a lot of traction. As I see also in the chat, where a few people have asked if how they can join the training. And perhaps you can give us just a brief update on the new module that it's going to be presented in the next few weeks on water pollution.
Sure. Do you want me to jump in now?
Yeah, just a minute. Yeah.
Yeah, sure. So in this new model, it's targeting healthcare professional as well, especially doctor, nurses, pharmacists, and healthcare managers. And it goes from the state of the art, understanding the problem, to understanding how antimicrobial resistance or pharmaceutical pollution is potentialized within water, understanding the science behind what is happening, how transduction are happening, to also walk them through the journey of taking step of changing. So through case studies, we have experts videos of Manjula and Alistair that are part of the experts interviews within the course, where they explain their practice, what they implemented within their yard, to see how you as a trainee, you can take those examples and integrate it within your practice. So that's what these modules is taking you through. We are finalizing it, and we will share it with you on our page at Healthcare Without Harm once it's ready in the upcoming month. So by May, it's going to be ready.
All right, thank you, Camille. Just to highlight a couple of your messages, I would actually highlight that training is key for behavioral change. And there is also something that I think it's very relevant, and it's the green gap that you mentioned. That green skills were not part of the curriculum until quite recently, and the planetary impact, let's say, of the healthcare sector was not considered, while it has some implications in public health. So it's really good that you also share with us your vision on how training could change this. So thank you very much. I saw also one question before we go to our last speaker, asking about the impact of switching from intravenous to oral. We might address this in the question and answer, but I wanted to take the opportunity to mention that we are going to have a session on the switching from intravenous to oral in CleanMed Europe. CleanMed Europe is the leading conference on sustainable healthcare in Europe, and it's happening in June. So you can go to the website. I'm pretty sure that my colleagues will share a link in the chat. But we will be discussing this among many other topics. So if you would be interested, I would suggest you go to the website and you register for the conference. And our next speaker will be Dr. Manjula Mehta. She's a consultant microbiologist and infection prevention doctor for Friendly Health NHS Foundation Trust. She has extensive experience in implementing interventions to reduce pharmaceutical pollution from hospitals, so it's working with different departments involved in building a hospital, from architects to IPC teams, just with the intention to build a safer environment, a safer hospital. So Dr. Manjula Mehta, the floor is yours.
Thanks, everyone. Can you see my slide?
Yes, we do.
Okay, perfect. I think there was such a good introduction with the last three speakers. It's made my job very much easier, actually. And what I'm going to speak today is about the built environment stewardship to combat antimicrobial resistance and antibiotic pollution. So as you've already heard, we all know, I think in this group especially, that antimicrobial resistance is the current silent pandemic, which is estimated to cost the global economy a huge amount of money, $100 trillion if we don't do anything about it, and to change the trajectory of how it's headed at the moment. And more importantly, the deaths due to AMR will exceed that of cancer very soon, again, if we don't do anything. And the focus globally has been on discovery of new antibiotics. And we know that this alone is unlikely to change the trajectory for a number of reasons. And I'll try and explain that. So if you look at what's happening in hospitals, patients who carry multi-drug resistant organisms, or MDROs, we see them more often in hospitals. And we know that these bugs are being excreted into the hospital drainage systems through their own body fluids. And we also know that we're using a huge amount of antimicrobials. The most broad spectrum antimicrobials are used almost exclusively in hospitals. And we know also that the hospital drainage systems carries a high bioburden of microorganisms. So coupled with the introduction of multi-drug resistant organisms and the huge amount of antimicrobials that we're throwing into our drainage systems, this is creating a very good selective pressure on the microorganisms, which means the most resistant bugs are being selected there. And also we know that especially the gram-negative organisms, there is a horizontal transfer of genetic material. So there is sharing of these very resistant genes between bacteria within drainage systems and potential creation of new resistance mechanisms. And also we're throwing a huge amount of biocides, like you've already heard, cytotoxic agents, many different things that also puts a lot of pressure on microorganisms that are present in our hospital systems. And we know a lot of sugary substances go into our drainage systems, which means that's food for the bacteria. And the temperatures are almost perfect for bacteria to thrive and multiply. So what we're creating in hospital wastewater systems is a perfect reservoir, or hospitals have become perfect powerhouses for transmission of AMR superbugs, but also generation of new resistance mechanisms. And we know that that leads to poor patient outcomes in terms of increased morbidity and mortality risks when compared to susceptible infections with susceptible organisms. The mortality with AMR bugs is at least 3 times. And not just the transmission risks within hospitals, what we're also doing is throwing these AMR genes and AMR bacteria into our municipal wastewater systems, again, like you've already heard. And this is causing, obviously, antibiotic pollution at an industrial scale from hospitals of our wastewater system. And that is just one newspaper article published just last month in the UK about how they found very resistant genes in the largest pond in Ireland, Northern Ireland. So if you look at what's been happening with plans to combat antimicrobial resistance through national action plans, we have so far focused a lot on judicious use of antibiotics in humans and animals. We've focused a lot on developing new drugs, although that pipeline is very slow and it takes a long time for new drugs to be developed. We've been reinforcing standard infection prevention precautions like hand hygiene, personal protective equipment, isolation, and decontamination. And majority of these infection control practices don't work for organisms such as the CPEs or carbapenemase producing enterobacterials, which are the very resistant gram-negatives when there is a persistent environmental reservoir. And we've also tried to focus a lot on improved diagnostics. But what has been missing so far, perhaps, is a focus on the built environment stewardship, or how there are reservoirs within the hospital itself that can be designed out, coupled with improved surveillance, because our surveillance has been so poor so far that we have never tracked the transmission of these bugs from hospital wastewater systems to patients. And within the UK, this is now included in the National 5-Year Action Plan for AMR for the first time. So through working with multidisciplinary teams, you can combat AMR transmission within hospitals by creating water and wastewater-free patient environments, and improving occupant safety, that is safety of every person who occupies the hospital, through better hospital design, construction, commissioning, and maintenance. And all of this has to be underpinned by better education and training. So while we are doing a lot of work now, and there's a lot of understanding within infection prevention teams on how AMR transmission can be prevented within hospitals, we have not looked too much into how we can prevent transmission of these bugs into our ecosystems. Like you've already heard, these bugs are going, reaching our agricultural produce, shellfish, from where these things have been isolated. And so some of my colleagues, especially my acknowledgements go to Dr. Weinbrunn, who's helped put some of these statistics together. We know already that 30 to 90% of all antibiotics that are given to humans are excreted unchanged in the urine or feces. And if you think about an average sized hospital, let's say a 600-bed hospital, the surface area that's available for microbial growth, so the biofilm formation, usually exceeds that of a football pitch. So there's a massive amount of bacteria, as you know, within hospital wastewater systems. And if we estimate that about 200 to 400 liters of wastewater is being produced per patient per day, the levels of antibiotics such as meropenem, we have estimated, even with very minimal use, say only 3 patients, for example, being given meropenem per day, will select resistant antibiotics. Will be with the levels that are produced in the wastewater system will be enough to select resistant pathogens. But in addition, we have got to remember that we're throwing quite a lot of other material like biocides, heavy metals, contrast, and all of these other toxic material down our wastewater systems. So what this essentially means is that the level of CPEs, or these most resistant bugs that we find in hospitals, the levels that they reach in hospital wastewater systems can be staggeringly high. So what's happening? So what are we doing actually with hospital or effluent? We know that within pharmaceutical industry there is some guidance, at least, around curbing the antibiotic pollution from manufacturing so that it doesn't reach wastewater systems. If you look at the animal industry or house, just our own communities, the use of antibiotics is limited in that we are using narrow spectrum antibiotics, and which are perhaps diluted in the wastewater system. So if we don't think that to be the major problem, the biggest problem that we see with AMR pollution of our wastewater system exists from the effluent that we see from hospital wastewater. And at the moment, globally, I think there are very few hospitals that are tackling the effluent that is coming out of hospital wastewater. Although there's technology already available that can prevent transmission of AMR genes and AMR bugs into wastewater systems, I think there's very little global action being taken in preventing hospital effluent from reaching water systems. So my key messages here are that AMR is an escalating global problem, which we all know, and that hospital wastewater systems are reservoirs for the selection and transmission of antimicrobial resistance pathogens. Well, transmission within hospitals can be prevented through improved hospital design and construction of the hospital-built environment. And this needs to be really underpinned by education and training of multidisciplinary teams. We are doing very little at the moment with healthcare wastewater systems, which forms the largest source of AMR entering our municipal wastewater systems. And most importantly, we need to focus on antimicrobial resistance national action plans and hospitals themselves taking responsibility to focus on how we treat hospital effluent before it reaches our ecosystems. So what the Healthcare Infection Society, which I am affiliated to, is doing about this is we've got a group called Spark, which focuses on research. And if you would like to be involved, please use that QR code. We've also got a working group called BIPI, which is the Built Environment Infection Prevention Initiative, which brings together everybody involved in constructing buildings, hospital buildings, to help make it safer and to prevent AMR transmission. And we have at the moment this is for the UK, but we have plans to make this a European BIPI and as well as global BIPI, with plans to collaborate with the World Health Organization and with the partners in Scotland. And lastly, the Healthcare Infection Society also run a course on water and wastewater safety in healthcare systems, which is aimed for all healthcare professionals who have an interest in water and wastewater safety and how it affects patient outcomes and how this can be designed out. And if you're interested, please use that QR code. And I think that's my last slide. Thanks everyone for listening. Stop sharing.
Thank you very much, Manjula. Thank you very much for this excellent presentation. You mentioned how very few hospitals are tackling hospital effluent. And I want to add to that it is even more worrying because knowing that hospital effluent gets together with community effluent, with agriculture effluent, which currently 70% of antibiotics used globally. It's a bit less in Europe, but at the global level, 70% come from farming. So everything gets together in the wastewater treatment plant. And of course, the wastewater treatment plant cannot process many compounds, so it sends them back to the environment. But also the selection of resistance happens also there. So it's a perfect mix, a perfect cocktail for antimicrobial resistance development. I know that we don't have much time, but I wanted to still ask a couple of questions. We might address one question quickly, and I can ask you for a message for our audience. So the first question that I wanted to address is a question that was made around what Ben presented on urine bags. So a few people asked about incineration and the potential also impacts that incineration has. I wanted to ask you if you know of any alternative treatment that can be given to these urine bags. Perhaps there is a water treatment system that can also process the water and then send it back. Can you give us a bit more information on this?
There are the absorption systems, so we will try to keep the patient for 2 hours in the hospital, and then they can pee. We collect all the contrast agents, and then it can be reused, not so much for making new medicines, but for other purposes. Especially this gadolinium is a very rare earth metal. It comes from China, and it's a lot of value in it. But the problem is how to keep patients for 2 hours in the hospital. It has been tried in Nijmegen, in another hospital, and the compliance was not really high. You have to really do something. And the best way I know the best way to keep patients in the hospital is that they get the result of the scan within these 2 hours, after 2 hours, and everybody would like to stay. But then you have to change the way the hospital works. But now the result is given within 2 weeks. And so this is but giving coffee or a free ticket for your car park, etc., that's not going to help a lot. We did some investigations in that. So it's really, again, changing the way the hospital works. If you say you get a result in 3 hours, everybody would like to stay. And so that's why I presented many options. I think we should proceed to a mixture of all these things to make it to get it. And if we are, and there was shortage of these conversations, and then the reusing it and repurposing, or yeah, that's certainly a way to go. But it would be a lot, make it even more healthcare, more expensive. In
All right,
short,
thank you.
yeah.
Thank you very much, Ben. I guess it's a question on who bears the costs and how we can make it more sustainable for everyone, of course. Since we don't have much time, what I would propose is that each of you can give a take-home message for our audience. I know you had many on your slides, but I guess we can try to have a last take-home message for our speakers. So I will do the reverse order. So I will start with Manjula, if that's okay to you.
Yeah, thanks. I mean, I think for me, again, the take-home message really is how we manage hospital effluent and whether we need countries and work to come together to find effective. I think Alistair put a good strat. You know, that strategy also works for antibiotic pollution. So a comprehensive strategy is really required to manage hospital effluent for risks of AMR.
All right. Thank you very much. Camille, you are next.
Sure. From my side, it would be that education and training embed but with behavioral science and behavioral change science are part of the solutions to mitigate pharmaceuticals pollution and AMR.
All right. Thank you very much, Camille. Ben?
Yeah, from my side, when we plan interventions in reducing these things, we would really measure whether they work really well. And just removing a parent compound from the sewage, it might not be the answer because many other products might be formed, so many transformation products. So there's lots to do. And even a simple thing like handing out a urine bag creates a lot of complexity. And so we are far from giving good answers on whether we do the right thing. Yeah.
I hope we will get closer with time. And last but not least, please, Alistair, the floor is yours.
Yeah, I mean, I think my main message is that we need to adopt multiple solutions to address this problem. And I think education is key throughout different stages, from school kids right through to medical consultants. Otherwise, we're not going to fix the problem.
Thank you very much. And thank you to all of you who have joined us today during this webinar. We have been over 100 people. You will receive an email with the recording of the webinar, and you will also receive a survey. So please complete the survey so that it helps us to make these webinars more useful for you. Thank you very much, and I hope all of you have a great day.